Hi, everyone. Thank you so much for joining us for this mini webinar sponsored by MyCares, the Michigan Cancer and Research on the Environment Study. Today, it's our distinct pleasure to have Dr. Anna Gottschlich with us to talk about cervical cancer. And January is Cervical Cancer Awareness Month. So it's really important to us that everybody is thinking about cancer prevention in general, and especially this month, cervical cancer prevention. Dr. Gottschlich did her PhD at the University of Michigan in our departments, as well as her master's degree in public health. So we've known her a long time. She's just really a star in this field. After finishing here at Michigan, she went on to the University of British Columbia for a postdoctoral fellowship. And you may remember in our last webinar, we had Dr. Rafael Meza, and she worked with him some in British Columbia, and of course here at back when they were both at the University of Michigan. Now she is an assistant professor at the Karmanos Cancer Institute, our close collaborators in the cancer world, and also has an appointment at Wayne State University. So Dr. Gottschlich, please take it away.
Hi, everyone. Thank you so much for having me. It's really a pleasure to be here and speak to you. Let me make sure my slides are advancing. There we go. So I'm really, really excited that I could come in and speak to you today. I have spent probably the last decade or so thinking about and working in the world of cervical cancer prevention. And it's truly amazing to see how much progress we've made over the last decade and how we are in a place where we can start to think about elimination of cervical cancer as a public health problem in the foreseeable future in our lifetime. And so I'm here to talk to you a bit about where we stand in the fight against cervical cancer, kind of what's new with cervical cancer prevention, updates to vaccination and screening guidelines. And I'll talk a little bit about self-collection screening, which was just in the past few months received FDA approval and is an exciting kind of extra tool to be used in the fight against cervical cancer. So, we all come from different backgrounds. So just to make sure, probably most of you know this already, but just to make sure we are all on the same page, I just wanted to quickly talk about what cervical cancer. So cervical cancer is a cancer that starts in the cells of the cervix, which is the lower narrow end of the uterus. So I'm not sure if you guys can see my mouse, but if you can, it's this part down at the bottom of the uterus. And it's a cancer that's unique in that it has sort of a slow progression. And like many other cancers, before the cancer appears, the cells of the cervix go through these changes known as dysplasia. So abnormal cells began to appear in the cervical tissue, but that is something that is able to be seen by a doctor, and those changes can be identified. And that's one way that we have really progressed in the prevention of cervical cancer. And I'll talk a bit about how we screen for cervical cancer. Early on, cervical cancer doesn't usually have symptoms, so it's hard to detect at early stages without screening. Symptoms usually don't start until the cancer has spread, but early symptoms might include vaginal bleeding after sex or after menopause, or between periods and discharge. And then some later stage symptoms might include bleeding from the rectum, difficult or painful urination, blood in the urine, and things like that. All of these are sort of general symptoms. So of course, if you are experiencing any problems, please see your doctor. But these are kind of the symptoms that do occur once cervical cancer has progressed a bit. And so I also just want to talk a little bit about the burden of cervical cancer in the United States. So you can see it really differs a lot by region. There are some areas in the South that have quite high rates of cervical cancer. There are some areas that have lower rates as well. And even if we look across the state of Michigan, the cases are so low in some of these places that it's been suppressed and we can't see, but we see that, there's a wide range of cervical cancer incidence even just across our state. And that has to do a lot with access to prevention. And the reason why we see cervical cancer everywhere is because cervical cancer is caused by this long-lasting persistent infection with a virus called the human papillomavirus, which causes virtually all cervical cancers. And this is a sexually transmitted infection. And so we see it kind of progresses around areas as it transmits between people. There's over 100 types of human papillomavirus. There's about 30 to 40 types that we think that are presumed to be carcinogenic. And there's 2 types, HPV 16 and 18, that cause 70 or more % of cervical cancers. And it's also important to understand that nearly all people who are sexually active will become infected with HPV at some point in their lives. And most infection goes away on its own through natural processes with your immune system. And these short-term infections do not cause cancer. What does lead to cervical cancer is lasting infections with HPV, with the human papillomavirus, that can lead to the changes I mentioned in cervical cells that would result in precancerous lesions, which, if those are not identified early, could develop into cervical cancer. And so people that are at higher risk for cervical cancer are people who become sexually active at a younger age or have multiple sexual partners, just given the nature of how the virus is transmitted. And then there are also some factors that increase your risk that you are unable to clear that infection and that the HPV infection will cause cervical cancer, such as having a weakened immune system, smoking or breathing in secondhand smoke, and obesity as well. So those just increase the risk that you are unable to clear the HPV infection, which is the cause of cervical cancer. And I think sometimes these talks about cancer are fairly depressing, but I think when we talk about cervical cancer, we can actually have a pretty positive talk because there's great news about cervical cancer. It's preventable. And so there's 2 main forms of prevention for cervical cancer. There's what we call primary prevention, which is the HPV vaccine. And that, receiving the HPV vaccine before you are exposed to HPV can prevent you from getting the most carcinogenic forms of HPV, thus preventing, or thus, significantly decreasing your risk of having of developing cervical cancer later. And even before we had the HPV vaccination, we had tools to screen for cervical cancer. So starting back in the 40s, there's this test that probably most of you have heard of called the Pap smear, where a doctor collects a sample from the cervix and looks at that sample to see if there are any cells that are differentiating or that look to be dysplasia. And if so that's just a screen. And if it appears that you are at higher risk for having a precancerous lesion, then you would be referred for a diagnostic test called a colposcopy or a biopsy, where precancerous lesions can be identified and then removed with a pretty simple surgical procedure. And once those precancerous lesions are removed, they're unlikely to recur. We also more recently have started doing HPV testing. So instead of looking for the precancerous lesion, what we do is that a medical doctor will look for presence of the HPV virus, the human papillomavirus, which is a precursor for the lesion. So we can even go a step further back and identify these precursors earlier on. And those who are HPV positive, we can keep a closer eye on them to make sure those precancerous lesions are not developing, or if they do, they can be removed before developing into invasive cancer. And like I mentioned earlier, cervical cancer usually develops fairly slowly over time. And so this graph is almost 20 years old, maybe 20 years old at this point. But I really like it a lot because it shows that around the age of sexual initiation, there's this big spike in HPV infection in the population. But as you can see, most of this blue line here, most of that HPV resolves on its own, goes away. And then, so that's kind of around between 15 and 20 years old. Then starting between 25 to 30 years, maybe we see this uptick in precancerous lesions that's resulting from these few kind of HPV infections that didn't resolve on their own. A lot of those get treated and go away. And then we see kind of, in the late 30s, early 40s or so, we start to see these cancers. And so from when a person has their first HPV diagnosed or gets infected with HPV their first time to when, if without any interventions, they might develop cancer, is kind of this 20-year period or so. And so as we see here, there's lots of times to identify and prevent the invasive cancer along the way. So if you're vaccinated, you kind of get rid of that exposure. You won't then get the infection that leads to cancer. You can also get pap tests over time, and you can get HPV tests as well to detect those precancerous lesions, remove them, and prevent invasive cancer. And so I just wanted to show these two pictures. I think they do a really good job of showing how well the HPV vaccination has worked. So the HPV vaccination is the safe and effective way to help prevent cervical cancer. And it was approved in the US in 2006. And so what this first graph is showing is it's showing the prevalence in percent of these different strains of HPV before. So the dark bar is before people were vaccinated and the light bar is after people were vaccinated. So if we take 16, for example, which is what we consider the most carcinogenic strain of HPV, we see that the prevalence was about 6% in the years leading up to when vaccination was approved and when girls started getting vaccinated. And we see that it, by just the 3 years following, dropped by 50% down to 3%. And here we can see it as well, based on vaccinated or unvaccinated, and in the overall population, we can see the prevalence of these types of viruses that are prevented by the vaccine. So you see that if we look among 14 to 19 years old, let's say, or let's look in a little bit slightly older group that would have been exposed to more HPV due to sexual interactions. So if we look at this group of 20 to 24-year-olds and we look in the vaccinated group, their prevalence of the vaccine, the types of HPV that are included in the vaccine, and this is before the vaccine. So this is, this is right when the vaccine was introduced in 2007, has already dropped down from before. So it's dropped down from about 18% before vaccinated to 14% in the first few years following vaccination, and then down to 2 or 3% in those next kind of 10-ish years after vaccination. And we do even see some decline in the unvaccinated cohort, meaning that maybe there's some protection as well afforded by vaccines, even to those who were not vaccinated. So a little bit more about the vaccine. So it's the vaccine that we use in the US is Gardasil 9. It's FDA approved for females and males age 9 to 45 in the United States. And it's called Gardasil 9 because it protects against 9 strains of HPV that are cancer causing or cause genital warts. And the HPV vaccine does not treat existing HPV infection, which is why it's so important and why they recommend to get the HPV vaccine at a young age. So right now, the CDC recommends that girls and boys get the vaccine at 11 or 12 and as young as 9. And that's really because it offers the most protection before someone becomes sexually active. So once people are sexually active, they may have already been exposed to HPV. And like I said, the virus won't help with the existing HPV infection. It really just prevents those infections before exposure. So that is why the CDC recommends starting it at or receiving the vaccine at an age before sexual initiation will have occurred. But for those who didn't receive it early, it's recommended up till age 26. And then also for adults between the age of 27 and 45, there are some cases where unvaccinated people can talk to their doctor about how it might make sense to still receive a vaccination at that age. So vaccination is one way of prevention. And then I talked about how screening is another important way to prevent cervical cancer. And that's for a couple reasons. That's because the HPV vaccination does not protect against all HPV types. Remember, it protects against 7 types that cause cancer, and then 2 types that cause genital warts. And there are about 30-ish that we think are associated with cancer. And so it's still important, even if you are vaccinated, and particularly if you're not vaccinated, it is important to still get screening. And as I mentioned, there's 2 screening tests that are widely used. There's the HPV test and the Pap smear, which is a cytology test. And so again, they identify HPV infections or precancerous lesions before they turn into cancer. And what I'm showing here is that what we're seeing here is that we're comparing, in this first graph, we're comparing women who did have screening versus those who didn't. And the women who did have screening, which are shown over here, have a significantly less, or their risk of developing cervical cancer is significantly lower. In the picture on the right, this is something that I think I published this about a year ago. We looked at the long-term risk of cervical cancer after either a negative HPV screen or a negative cytology screen. And we see that this is just after one negative screen, the risk stays very low. And in fact, it stays particularly low among those who are HPV negative. And I'll talk to you about why that's important on the next slide. But we see very, very low risks of even developing cervical precancer after a negative HPV test. And so these are the US screening guidelines for right now. There's 2 major guidelines that clinicians follow. One is the United States Preventative Services Task Force, and the American Cancer Society also has recommendations for cancer screening. So the USPSTF recommends cervical cancer screening for every 3 years if you're doing cytology alone for women from 21 to 29. But then once you hit 30, they have 2 separate recommendations. Either 3 years if you're just doing cytology, which is the Pap smear, or 5 years if you're getting HPV testing, or something that we call co-testing, which is when a clinician gives both the HPV test and the Pap smear at the same time. And the reason why this can be extended to 5 years, if you're including the HPV test, is because if we go back to here, we see that the risk after a negative HPV test is so much lower compared to the risk after a cytology screen. So the cytology or the Pap smear is the purple and the blue bars, and the HPV is the green and the red bars. And we see that the risk of cervical precancer after a negative HPV screen stays very low for a long time, which is why the recommendations have allowed screening to be extended to every 5 years. And the American Cancer Society has similar recommendations. So they recommend starting at 25 years older, so a few years older. And they recommend everyone should have a primary HPV test. So they're just saying HPV testing is the way to go. If HPV testing is not available, screening can be done with either a co-test. So that, again, is an HPV test and a Pap smear every 5 years, or a Pap smear every 3 years. But American Cancer Society has come out with the statement that HPV screening is superior to cytology and should be used whenever possible. And so then something else that has happened recently, and this was very cool for me to see, because when I got into public health in 2014, one of the first projects I ever did was looking at the acceptability of self-collection screening to screen for cervical cancer. And then just last year, the FDA finally approved it. So that was great to see. But I wanted to talk a bit about what is self-collection cervical screening. So it's a vaginal swab. It does not need to to go all the way up to the cervix. If you see on the screen here, it just gets inserted into the vagina. And you can do it yourself. It's similar to inserting a tampon. It's used to collect a vaginal sample that then is tested for HPV. So it was approved for use in a clinical setting last year in May. And I also want to mention it was approved for use at home last January in British Columbia, Canada, which is where I was doing my postdoc. And a lot of the research I did throughout my postdoc was evidence that we provided to the provincial health authority to help them make this decision to approve home use for screening. And I think likely in the nearish future, the FDA will also approve self-collection screening for home use as well. There's been lots of global research on the acceptability of self-collection. The majority of people who use self-collection find it easy to use and comfortable. And there's also lots of research that has demonstrated that self-collection is as accurate as physician-collected. So if that's something that sounds appealing, that's something that should be available at many clinicians' offices, either already or in the near future. And so because of all of these kind of updates to eliminate cervical cancer, the World Health Organization actually released an elimination strategy a few years ago with a goal of vaccinating 90% of girls with the HPV vaccine by age 15, and getting 70% of women screened at least twice in their lifetime with an HPV test, and treating 90% of women identified with cervical disease. And according to the modeling done by the World Health Organization, accomplishing these goals will result in being able to eliminate cervical cancer as a public health problem, which is set at a rate of 4 per 100,000 women. And right now, the rate in the US is 6.3, but appears to be decreasing. And with that, I will stop and thank you for your time, and just encourage everyone to, if you fall into those recommendations, to make sure you get screened and you get vaccinated and help prevent cervical cancer in your community. Thank you.
Thanks so much, Anna. That was great. And this is an area that I think is particularly near and dear to our hearts at Michigan, where you started your career in this area. We have one question so far from the audience, and I encourage anybody in the audience to put your question in the chat or the Q&A. The first question is, so how is the HPV test done, and what's the difference between colposcopy and an HPV test?
That's a great question. So the HPV test is a swab that collects a sample from the vagina, and then that sample is put through a PCR machine, and which is a quantitative machine. So there's no sort of subjectiveness to it. And that machine will identify the presence or lack of presence of HPV. And so the HPV test set, you can collect it yourself, or a doctor can collect it just with a vaginal swab. Kind of like, I don't know, maybe this is like not a great picture, but like the nasal swab for COVID, but for your vagina instead. So that's kind of where the world is going in the way of screening. What we used to use, and what some people still use, is the pap smear, which is a cytology screen. And what that is a clinician scrapes cells from the cervix. So further up, it needs to go all the way up to the cervix. They scrape some cells from the cervix, they put it on a slide, and then they give it to a pathologist who looks at the cells under a microscope and decides whether those cells look like they have dysplasia. Do they look like they are turning into cancerous cells? So this test has a lot more subjectivity because it is a person with their eyes saying, I think these cells look like they are differentiating, that they're moving towards cancerous cells, or they're not. So those are the two tests. Then, but these are both screening tests. So a screening test never means you have the disease. A screening test means you are at higher risk for the disease. And so if your screen comes back positive, Depending on the level of severity, either they might say, okay, come back in 6 months, come back in a year, we'll do it again. Or they might say, you should go for a colposcopy. A colposcopy is just a closer look at the cervix. So a doctor will use a microscope to look at the cervix, or not a microscope, a magnifying glass to look at the cervix, and then potentially usually take a biopsy. So they'll cut a little piece of the cervix out, and then they'll have someone again look at it under a microscope and look at if the cells, what's going on, if there is an appearance of a precancerous lesion. If then there does appear to be a precancerous lesion, then you're often referred to something that's called a LEEP, which stands for loop electrical excision procedure. And so that is just, they take this metal loop, a metal circle that has been heated up, they cut out the lesion, and you move on with your life. They keep you under, you come in, you come back and get checks, but for the most part, once that precancerous lesion is removed, there's no recurrence of disease.
Perfect.
And again, I'm not a medical doctor, so if you have more medical questions, please, all of your clinicians will be able to answer those as well.
Yeah, no, but that was a great description. The next question relates to the American Cancer Society recommendations. And so Thomas is saying, given the wide availability of HPV testing from clinical laboratories, please comment on the suggestion that HPV testing could be described as unavailable, or that co-testing could be deemed a more practical alternative to primary HPV testing.
Yeah, so this is something that I have been learning more about with my move back to the United States. So it seems as though, and again, I think that this is just really differs by location, but I think some labs are not set up to run HPV tests that have been approved by the FDA as primary HPV tests. So there are some HPV tests, from what I can tell, there are some HPV tests that are approved to be standalone HPV tests, and they can be done without the co-test. And there are some HPV tests that have been approved to be part of a co-test. And so I think that has caused some delays in labs being able to transition from co-testing. Co-testing has been available for much longer. It's only been recently that these recommendations are transitioning to recommending HPV without the co-test. And I think that some of the labs are lagging behind in their ability to run a primary HPV test without the corresponding cytology screen due to approvals in these screens. I think there are also maybe some issues with billing insurance that need to be resolved as well. And I think that these will be cleared up over time. So like I said, the American Cancer Society has come out with their recommendations of primary HPV. The United States Preventative Services Task Force is actually in the process of updating their cervical cancer screening guidelines. I think they're near the end of that process. So when they release their new recommendations, I guess we'll see if they've kind of followed the ACS in their recommendation for primary, or if they're still recommending kind of primary or co-test or cytology. But I think, assuming that they kind of also start recommending primary HPV, some of these things that have lagged behind hopefully will catch up.
Super interesting. One of the things I've always found a little confounding is that the ACS guidelines are to start at age 25, and the U.S. Preventive Services Task Force is to start at age 21. So, and sometimes people will ask me, and I'll just be like, I'm certain there is evidence to support both, and that's sort of all I've got. But I'm curious if you think that the U.S. Preventive Services Task Force revised recommendations will start at 25.
I think it depends on whether they, from the literature and from the research, the reason you might want to start at a slightly later age is because there was that graph I showed with the bump in HPV infections. And so that bump in HPV infections is really happening kind of in the late teens, early 20s. So if you start screening at age 21 and you're using HPV as your screening test, you're going to catch all of those new infections where the majority of them are just going to clear up on their own. And so I think that my guess is the reason that the ACS increased the age to 25 is that when you hit 25, okay, hopefully you've gotten that, I mean, not hopefully, but you've cleared that first HPV infection. And now the HPV infections that we're detecting are some of these infections that didn't clear so quickly and maybe are turning into an infection that might eventually lead to cervical cancer.
Super interesting. We have two related questions, and so I'll just kind of describe them. The first is if you have had a LEAP already, presumably you have had an HPV infection. Is there value in getting vaccinated after that time? Because perhaps it would protect against other strains.
So I think that is an underexplored question. I know that is a question. So I know less about this in the United States, but in British Columbia, after a LEAP is done, they give an HPV vaccination at that time. So they'll conduct the LEAP and then they'll administer a vaccination with the idea that hopefully it prevents future infections if someone was going to be exposed again. I think, and then actually we have this project we've been trying to get going to look at the risk of a new HPV infection or the risk of a new precancerous lesion after receiving that vaccine that we have not gotten going yet. And I don't think that there is research out there. In theory, it should, protect you against strains of HPV you have not been exposed to. I don't think the literature is out there yet that can definitively say whether it actually does lower risk of developing cervical precancer.
Yeah, I know clinically here in the US, especially among people who are immune compromised, this will be done. I don't know in the non-immune compromised population. Yeah. And so somebody has asked, what if you've had a cone biopsy? Is that the same as LEAP in terms of a vaccination post-treatment? And I think the answer would be yes.
Yeah, I think so. They're very, very similar procedures. So I would imagine yes.
Yes. And so Chrissy has a related question, but it's just a little bit nuanced. And that is that if someone has an HPV infection and gets the vaccine, is there any proof that it could help clear the HPV infection?
I don't think so. No, I don't think that there's any evidence out there to suggest it helps clear the existing HPV infection. But again, there are 30-something, I think it was 37, now maybe it's 36 strains of HPV that are associated with cervical cancer. And so, if you get vaccinated and you've been exposed to some but not to others, that vaccine could prevent becoming infected with those other strains.
Perfect. So an important question from Alexa, which is where can we get the self-collection screening test for home? And does it give you results of what type of HPV you have, or is it just that it was positive?
Yeah, so right now the FDA has not yet approved at-home self-collection. So right now in the United States, self-collection can only be done in a clinician's office. And I'm not sure what information. I haven't myself, I have not done a self-collection one here in the US, and I'm not sure what information is given back. I know now, so originally the original HPV tests just said positive, negative, and they didn't tell you at all. There was no sort of genotyping. They didn't say, oh, you're positive for these strains. When you got the results back, it was just positive, negative. Those tests are no longer regularly in use. So the HPV tests that are available now, some will tell you if you're positive for 16, 18, sometimes 18 or 45, because they're very similar. And then the other types, because 16 and 18 are the most cancerous, the most carcinogenic. So it will say a positive for 16 or positive for 18 or positive for an other high risk strain. And that's kind of the most common. And then there are some tests as well that will tell you exactly what strain you're positive for. Because these tests are being taken in a clinician's office, I'm not sure what information then gets back to the patient. But I think depending on what test you take, you could ask your clinician, do you know what types I was positive for?
Yeah. I mean, it's interesting when the FDA approved self-collection in a clinical setting, which feels a bit counterintuitive to the goals of self-collection. It was certainly a step forward, but not like what you had in British Columbia or in many other countries across the world. And so we have this last mile study, SHIP, which is presumably going to convince people that it can be done at home. What are your thoughts around the SHIP trial, and kind of if you have any thoughts around timing of when we might move forward with at-home testing?
So I think it's interesting because all the research out there has kind of shown that women are able to collect this test at home just as well as they're able to collect it in a clinician's office, which obviously, I think, I don't know, Lee, I think that in the world we are today, who knows what will happen with these big NIH studies. I think we are in the last mile, and that a lot of these barriers to screening, if we go back to that map I showed at the beginning where we see the states, kind of some of the rural states in the South are red. A lot of the reason why we see those really high rates of cervical cancer there is that people don't live near a clinician's office. They don't live near a doctor's office. They can't get to a place where they can get screened. And so being able, we know that these tests, we can mail these tests to people. They can take them, they can put them back in it. It doesn't have to be climate controlled. They can just mail these tests back in, and they're stable. The samples are stable. We can test them a week later and they still have what we need to be able to do the screen. And so I'm really hoping in the near future, home use is approved, because I think that will really reduce a lot of these barriers we see that are allowing women to fall through the cracks and get cervical cancer, which, as we know, or hopefully as we know from today, is preventable.
Yeah, it's very interesting. I mean, in the US, there have been a number of studies showing that in underscreened populations, HPV self-testing is acceptable. Some of our work in the Arab population is quite interesting because it has shown that it is acceptable and may overcome certain barriers. I would say what we gleaned is that the Arab population that was included in our study would rather do the self-collection at a doctor's office. And so I think that there's value in having both options available, really.
Yeah, we certainly saw that. Well, I think Lee, maybe you were part of it. We did a similar self-collection study in Thailand, probably in 2015, 10-ish years ago. And we saw something similar where there were certain groups who definitely expressed that they preferred self-collection, but in the clinical setting. So yeah, I think certainly having both choices available is kind of the gold standard, is ideal. But I do think kind of we need to make it available at home as well. There's no reason not to make it available.
I mean, it's very strange because
Yeah.
I'm not sure what evidence we're still looking for, but that's, my opinion. So Jason has an interesting question, which is, from a global perspective, is the trend in cervical cancer happening across the board? And what about vaccination rates and availability?
The trend in cervical cancer incidence, or in the shift to HPV?
I think the trends in decreasing incidence that we see here.
Well, so I did not show a global map because I wanted to think about cervical cancer more in the context of Michigan and the US. But across the world, we see very different rates of cervical cancer. If we look in kind of Central America, Sub-Saharan Africa, Southeast Asia, we see these very high rates of cervical cancer, in large part due to, as expected, lower vaccination rates and lower screening rates. And so as and there have been a lot of these sort of like pressure to make HPV vaccination more affordable globally. So hopefully we will get to the point where HPV vaccination we can increase rates around the world. And we need to make HPV screening affordable as well. There is, again, a push to have affordable self-collection HPV screening tests. But I think across the world, we are seeing this transition to HPV screening because it does. So one thing I didn't mention is that in places with less resources, cytology is not often used. What's used is something called visual inspection with acetic acid. And so this solution is applied to the woman's cervix, and you look to see if spots turn white. And it works okay, but it doesn't work great. And so as better tests are more affordable and thus more available kind of globally, we will hopefully see this reduction in incidence. That is the whole goal of the WHO's elimination plan. It's for every country to implement those 3 pillars that I mentioned, with the goal of every country having an age-adjusted rate of less than 4 per 100,000 women diagnosed with cervical cancer per year.
Yeah, so I just can quickly show the cervical cancer incidence across the world, where the darker blue is 30.2 or higher cases per 100,000. And so as Anna said, you can see there are these areas in Africa, South America, where rates are very high still. So we certainly have a lot of work to do globally, for sure. One of the things that I think you just mentioned had to do with cost. And so one of our participants asked if we know the cost if insurance isn't covering it.
So I don't, but what I do know is that there are these programs across Michigan. So in the Tri-County area of Detroit, there is something called the BCCCP, the Breast and Cervical Cancer Screening Program, that will provide breast and cervical cancer screening for under and uninsured women. So if you don't have insurance, or if your deductible or copay is more than you'd be able to pay for a screen, these programs across Michigan will cover the cost of your screening. They'll cover the cost of follow-up. And then if you do end up with, let's say you are diagnosed with cervical cancer, they will help get you enrolled in Medicaid to pay for that treatment as well. So these are programs that are funded by the CDC. I think there are 11 different ones throughout Michigan. So I mentioned the one in Metro Detroit, but I think there are ones elsewhere. And those, so in theory, cost should not be preventative for screening. If you are experiencing cost burden that prevents you from screening, try to find one of these CDC funded programs that will pay for breast and cervical cancer screening.
Yeah. It's a really important program that we have here in Michigan. So I think that's great. I will note that it's 12:47. So we're a little over time. Are you okay to stay and answer a couple more questions?
Yeah, no worries. I have a meeting at 1, but I have 13 more minutes.
Okay, excellent. So just going back to the last question, part of it was about coverage for the vaccine or cost for the vaccine. And particularly the question was around if you have aged out of that kind of 26 age bracket. And so what I can say is I work with someone who I know is very effective at getting insurance companies to pay for people up to, I think the upper age is now 45. Mm-hmm. And, it takes some time on the provider's part to write a letter of medical necessity and so on. I don't personally know the cost if you have to pay out of pocket. I don't know if you know what the cost of HPV.
Oh, I'm sorry. The question was about paying out of pocket for vaccine, not for screening. Sorry.
It's okay. It was super important information. So
no, I don't know. I don't know the cost of paying for the vaccine out of pocket. No.
Yeah, but I think I would certainly encourage you to talk to your physician about writing a letter of medical necessity because that is often successful, for sure. Okay, let's just see where we are. So again, another really important question is if you test positive for high-risk HPV and you have a colposcopy and subsequent treatment, how often should you get screened after that time point? Do the recommendations change for someone who's had a positive test?
Yeah. The recommendations do change, and I can't give you an exact answer because I think it depends on type of HPV, kind of the level of the lesion, things like that. So, and probably doctors as well. So there aren't as clear guidelines for screening after treatment, but I think in general for the next few years, maybe 3-ish years, they have you coming every 6 months to a year to follow up. And then after a few years, and again, I think it's kind of dependent on the doctor and dependent on the treatment you had and how the size of the lesion, the type of HPV, things like that. But after a few years, they will return you to regular screening because your risk will have gone back down to that of the general population.
Perfect. I'm going to ask a question myself, just because I am asked this question a lot. So I think it would be great for you to talk about it. And that is, why would boys get the vaccine, or why should boys get the vaccine since they don't have a cervix?
Yeah, that's a great question. There's 2 reasons. There's the individual reason, which is that HPV is also related, not as strongly. So we know that HPV causes over 99%, essentially all cervical cancers. HPV also is a cause of penile cancer, anal cancer, head and neck cancer. So a lot of other cancers that do affect men, boys, men mostly. So that's one reason, is that getting vaccinated for HPV decreases the risk of these other cancers that men do get. That so then your risk is decreased there. The other is not doesn't necessarily give individual benefits, but we know that HPV is a sexually transmitted infection. And so if boys are vaccinated against it and then they can't get HPV, then they can't spread it to, then the men can't spread it to women. And so it creates this, what we call herd immunity, which is that, even women who do not get, so everyone should get vaccinated, but if we vaccinate boys as well, it causes just less transmission through the population, which then brings down the amount of HPV in the population, and so it can decrease risk of cervical cancer for women as well.
Yep, super. All right, well, I can't thank you enough for doing this webinar for us in this very important month of cervical cancer awareness and in our shared goals of eliminating cervical cancer. I want to thank all of the participants for joining us, and also the Michigan Cancer and Research on the Environment Study for sponsoring the webinar. We will see you in 2 months with another webinar that we'll push out to everyone. Thanks so much.
Thank you, everyone.